Now, HACE is actually pretty rare below 3,500 meters, but it starts to increase in severity and propensity as we go to higher altitudes. And in most cases, it's preceded by about 24 to 36 hours of symptoms that would be compatible with AMS. And one of the cardinal features is that the patient has persistent postural headache that is not resolved by simple measures. They continue to climb, the headache gets worse, and then gradually they start to develop the neurological features indicative of high altitude cerebral edema. And one of the cardinal signs, and one of the signs that we place the most significant importance on, is the development of ataxia. And if you start to see someone on a climb who's developing features of ataxia, particularly if associated with any cognitive changes or changes in consciousness, that is a absolutely pathognomonic feature of the development of high altitude cerebral edema. Those patients need to be descended as quickly as possible. Because obviously as HACE progresses, you start to develop irrational behavior patterns, person becomes increasingly confused and disorientated, there are substantial progressive cognitive changes, blurred vision, lethargy, seizures, coma, and ultimately progression to death. And in fact, death can occur in as little as 12 hours from the onset of first symptoms, and in some patients, you'll progress rapidly to features of HACE without actually seeing the preceding features of AMS. So again, on a mountain, you need to maintain a high index of suspicion for the possibilities. Postmortem findings in high altitude cerebral edema simply confirm what we are saying, that there's gross cerebral edema, petechial hemorrhages, subarachnoid and ring hemorrhages, and evidence of herniation of cerebral tonsils and unci. In other words, death due to elevated intracranial pressure. Okay. What is the treatment of acute mountain sickness? Well, before we talk about drugs, the first thing to say is that in virtually any acute mountain syndrome, whether it's AMS, HACE, HAPE, etc., the fundamental treatment is to descend. And descent, in most cases, will result in a dramatic improvement, often with as little as 200 to 300 meters of vertical descent. However, not everybody needs to descend, and people who've got relatively minor symptoms can be managed at altitude and potentially can climb further as long as the pathophysiology of the nature of their condition is understood, there's a clear and critical evaluation of their symptomology, and they've got good guides who actually understand what's going on and know when and how to intervene. Leaving aside descent, the drug of choice, if you're going to think about a drug to treat AMS, is Diamox or acetazolamide. This is a carbonic anhydrase inhibitor, and it has a whole range of potential benefits. Now, I don't want to go into this in too much detail, but fundamentally, Diamox or acetazolamide inhibits carbonic anhydrase activity in multiple places in the body. It inhibits that function in the carotid body, in the kidneys, in the brain, and it also has effects in blocking calcium uptake in pulmonary artery smooth muscle. And as a consequence of this, it has a number of effects. It can improve sleep by decreasing periodic breathing. It can increase ventilation, thereby allowing you to blow off more CO2 than you otherwise would be capable of. And remember what we said before about the alveolar gas equation, that the more you hyperventilate, the better you can oxygenate. Increases in ventilation are actually a consequence both of effects on the kidney and on the brain. And in terms of its effects on calcium uptake, it decreases hypoxic pulmonary vasoconstriction, which means it smooths out ventilation perfusion matching in the lungs and has an effect on being able to improve your exercise capability at altitude, which obviously can have a significant benefit. Now, Diamox is also a weak diuretic, and it does appear to be some benefit from its diuretic effect, although we're not quite clear why. And in fact, we do know that giving diuretics per se probably offers no real advantage in terms of prophylaxis or treatment of acute mountain sickness. Diamox itself, we should remember, started life as an antibiotic, and then it turned out to be a pretty poor antibiotic, so then it became a diuretic. It didn't become a diuretic, it of course always had diuretic effects, but it was utilized for a while as a diuretic. But of course it's not a great diuretic either, and so its initial principal two uses have well and truly sort of fallen out of favor over a protracted period of time. But acetazolamide is proven in randomized controlled trials and meta-analyses. It is shown to have a prophylactic benefit in terms of preventing the development of acute mountain sickness, and it's also shown to have a benefit in the treatment of acute mountain sickness. And as we can see here, the main benefits are that it reduces AMS symptoms, it improves exercise performance, it maintains oxygenation during sleep, and it reduces periodic breathing and prevents extreme hypoxia. For prophylaxis, the dose is 125 milligrams BD. You, generally speaking, should start it 24 hours before you arrive at your high altitude environment. And once you've reached your peak altitude and you've started your descent, there really is no advantage in continuing with Diamox, and you can stop it at that stage. Note that in Australia, Diamox does not come in a 125 milligram formulation. It only comes in 250 milligram tablets, and so you do have to cut them in half. There's no reason, technically, why you can't take 250 milligrams BD, but there's no additional benefit in doing so, and you simply increase the risk of potential side effects. And of course, like all drugs, there are side effects. There are allergic reactions that are possible. Remember, this is fundamentally a sulfur drug. Diuresis, we did say it is a diuretic. Not a great diuretic, but it's still a diuretic. And whilst it might improve sleep from smoothing out periodic breathing, it can disturb sleep by making you get up to pee at night. One of the most troubling features is it causes a paresthesia, pins and needles, which can occur in your fingers, in your hands, in your feet. And whilst that might just be nuisance value in some situations, the tingling and the pins and needles sensation can actually become very significant, almost painful, to the extent that some people will actually abandon the use of Diamox. Loss of appetite, nausea, vomiting, diarrhea can occur. Definitely causes an altered taste sensation because of the effects on carbonic anhydrase in your saliva, and a lot of food will taste metallic. Alcohol will often taste metallic also, and carbonated drinks will taste flat. It can sensitize your skin to sunlight, thereby leading to a sort of photodermatitis, and it can also cause a transient myopia in some cases, where people have actually effectively become so short-sighted as to be perhaps effectively blind, which obviously does not allow you to trek at any altitude with any significant level of confidence. An alternative to prophylaxis with Diamox is dexamethasone. However, it has significant side effects and is probably not the ideal first choice. I would only use dexamethasone if acetazolamide was not tolerated. Dexamethasone can sometimes be used in conjunction with acetazolamide if you're in a situation where you want to make a rapid ascent to high altitude and you're trying to maximize the prophylactic benefit by using both agents. This is probably not something that should apply within the civilian world, but may have a role to play perhaps in a military environment. The dose of dexamethasone is generally accepted to be 8 milligrams per day in divided doses, which can be given either as BD or QID. A whole range of other drugs have been mooted as having a potential benefit in AMS prophylaxis. These include codeine, aspirin, theophylline, spironolactone, ginkgo, and coca, or coca leaves. And none of these have actually ever been shown to have any benefit. So whilst certainly they are used and in some cases advocated quite widely, there's no actual evidence base to support any of these. In fact, coca leaves are particularly interesting. They're widely used in South America. The local Andean population believes they have a phenomenal benefit, and they are used by literally tens of thousands of people. However, again, despite that, there's no evidence to support that they have any actual benefit in improving acclimatization. So, to put that together into a pragmatic approach, if you have AMS and your Lake Louise score is around 3 to 4, you can stop ascent. In fact, you obviously should stop ascent, and it's quite reasonable to wait at your particular altitude and monitor progress. Treat by rest, hydration, simple analgesics such as ibuprofen and paracetamol, antiemetics if you're feeling a little bit nauseous. Sleeping slightly propped up might actually have a little bit of a benefit in terms of easing any headache. Avoid sedatives, in particular alcohol. Start acetazolamide if you haven't already, and generally monitor the response. And for most people, symptoms will generally resolve over 24 to 48 hours, and then they should be able to continue climbing. One of the difficulties in this regard for people on modern day guided expeditions or guided trekking trips at high altitude is the commercial realities that these trips are being run quite fast. So for example, if you're on a 5-day climb of Kilimanjaro, there's no way you can afford 24 to 48 hours to wait at a particular site and see how someone gets on. In general, in this sort of scenario, you're probably going to get sent back down. If you're climbing Everest, where you might well be spending 6 to 8 weeks at base camp, then it's a different scenario, and it's perfectly reasonable to spend 1 or 2 days resting with the opportunity to then obviously continue your climb thereafter. None of this is an option with a Lake Louise score of 5 or above. Here, the key is descent. Yes, you can start acetazolamide, and bear in mind for treatment, the dose of acetazolamide is 250 milligrams BD, as opposed to the prophylactic dose, which we mentioned before was 125 milligrams BD. At the same time here, you should start dexamethasone if not already on dexamethasone, and you can consider oxygen, the use of hyperbaric chambers or CPAP. These are all effective, but of course these particular modalities are limited by logistics, and most expeditions or most treks will not have access to oxygen, hyperbaric chambers or CPAP. Ultimately, the key here is descent, and the use of drugs or any other adjuncts is simply to buy you time to get the patient down. You should never leave the patient alone in these circumstances, and you certainly shouldn't allow the patient to be the one that makes decisions, because in the early stages of significant AMS, patients can have quite marked impairment of their cognitive abilities, and they'll often think themselves as being superheroes who want to reach the summit at all costs, and they will make very poor decisions under those circumstances. You should be descending people until symptoms resolve. Sometimes as little as 300 meters might actually have a significant impact, but ultimately the key is get them down. High altitude cerebral edema is essentially a no-brainer. Immediate descent. There is absolutely no choice here. The patient not only has to be descended, they've got to be gotten totally off the mountain, and they need to get to a hospital facility as quickly as possible. Certainly they may show a dramatic improvement with as little as 300 meters of descent, but even if they do show a dramatic improvement, they need to be evacuated off the mountain. Again, the use of dexamethasone and the use of acetazolamide will have a benefit, but it's predominantly to buy you time to get them out. If you have oxygen available, it is of benefit, both in severe AMS and in HACE. You should target for SATs of greater than 90%. Obviously, on most expeditions, oxygen is limited, if available at all, bearing in mind that oxygen comes in cylinders, cylinders have to be carried, and cylinders are extremely heavy. Decompression chambers, I'll talk about those on the next slide. And diuretics, there's really no benefit in utilizing diuretics in the field for HACE. Okay, just a word on decompression chambers. You may see them used from time to time, although it's not that common. These are lightweight, well-tested and relatively cheap devices. They are essentially a chamber in which you place the patient and then artificially increase, or rather decrease, their effective altitude. And what this does is it allows you to effectively simulate a descent of up to approximately 2,500 meters, depending on the design of the chamber. They are relatively easy to use, but as you'll see in a second, they're quite tiring to use, and there are some technical aspects that have to be taken into account. There are 3 main types of chamber: the Gamo, the SirTech, and the PAC, but they fundamentally work in the same way. The Gamow bag was invented by Igor Gamow, and just out of interest, he was the son of George Gamow, who was one of the main authors of the Big Bang Theory of the universe. And you can see here a Gamow chamber. It's essentially a large chamber in which the patient is placed, but large is a relative term. I'm sure you can imagine that being in this, particularly if you're feeling unwell, would be extremely claustrophobic. And remember that with both AMS and with HACE, you can feel not only nauseous but vomit, and if you were to vomit inside this chamber, again, that could be a potentially catastrophic situation. The Gamow bag is not quite as efficient as the SirTech bag. It simulates a descent of up to approximately 1,500 meters. We've already said how it can be claustrophobic in here. It can also get very hot and very cold, and you don't actually have any real access to the victim once you've placed them in there. And once you've placed them in there, Getting them out can be tricky because, of course, that effectively is a rapid decompression scenario. It can be difficult to carry. Remember that one of the keys in using such a chamber is no different to using dexamethasone or to using acetazolamide. It's to buy time to get the patient lower down. The way this works is that it has a foot pump, and by pumping this with your foot, you effectively pump gas into the chamber and you effectively induce an artificial increase in pressure, which then simulates a decrease in altitude. Now, you've got to keep pumping this to actually maintain the pressure in here. You've also got to keep pumping here to actually maintain a flow of gas, because if you stop pumping, not only will the pressure in here actually decrease, but the patient will continue to breathe out CO2, which will accumulate, and the patient will effectively asphyxiate. And that's obviously partly here why using these things can also be extremely tiring. The SirTech bag is just a different version. It's a double bag, double zips, double valves, making it more durable in the kind of outdoor trekking environment. There's a bigger window, so it makes it a little bit easier to see the patient. It can simulate descent up to about 2,500 meters, and it has a double action pump which inflates on both the up and down stroke, which means less work in terms of the person who's got to do the pumping. It is lighter than the Gamo, but it is a little bit more expensive. And here you can see a SirTech bag, and you can see here slightly different pump mechanism. The important thing if you're using one of these on any expedition environment is obviously to understand exactly how it works, and not to pump it up for a while and then go away for coffee and come back and find that your patient's essentially asphyxiated. Really, these are only going to be used on high-end expeditions that are going to extremely high altitudes, probably in the order of somewhere between 6,000 and 7,000 meters. Once you get higher than that, then in actual fact it becomes quite impractical to use one of these chambers. For example, if you're climbing Everest, you're never going to see one of these chambers used above the high camps, because the logistics really make it essentially impossible. So, Kilimanjaro, would you use a SirTech bag there or a Gamo bag here? Fundamentally, as we've already said, the altitude here is less than 6,000 meters above sea level, and one of the things about Kili is that it is essentially quite easy to descend fairly quickly. And so a Gamo or a SirTech bag would actually be distracting here. The priority if somebody is developing AMS, HACE or HAPE and requires immediate descent is first and foremost to recognize that that's what's going on, and then secondly to activate their descent relatively quickly. And the beauty of Kili is you can get them down hundreds of meters very fast.